Can I now request Dr. Madan Kumar from Apollo Chennai to give a talk on important topic of when is enough, when to call off ECMO, ethical and legal issues.
I'd like to thank the ECMO Society of India and Dr. Suresh Rao for giving me an opportunity to talk about ECMO, when to call it off, the ethical and legal issues. And it's a very interesting topic and of course a challenging situation for any ECMO specialist. So, the left hand side is the Hatfield Hospital, London, where I got trained, and right hand side is the Apollo Hospital, Chennai, where I practice ECMO. The content of my talk will be on the introduction, how to avoid issues like controversies, ECMO, when to call it off legally and ethically, and case scenarios, future suggestions, and solutions. ECMO is generally justified if you are going to initiate it for a reversible condition, or as a bridge to transplantation, or as a bridge to decision making. But having been introduced to the ECMO, sometimes we come across a situation where you initiate for a reversible condition, but the patient turns out to be irreversible, or else the candidate may be a candidate for transplantation while initiation, but slowly turns out to be not a candidate for transplantation. So at that time we are in the dilemma, or else we are forced to run the ECMO where as a bridge to nowhere. So in that situation, we come across these ethical legal issues and end-of-life discussions. Non-controversies are very clear. The patient recovers and goes home fine, we are all happy. But the other thing is irreversible organ damage, where one can't sustain the life. Next is irreversible single organ failure with the option of transplantation or mechanical circulatory support. We don't have any issues on that. We are not going to go into the detail. But the controversial issues, like a patient on ECMO, who has a good perfusion and preservation of all the organs, but there is no chance of survival outside the ICU. Uncertain diagnosis, especially in ECPR, effectiveness duration of ECMO is unclear, or irreversible organ damage with stable hemodynamics, or irreversible single organ dysfunction without option of transplantation or mechanical circulatory support system. Why these controversies? Usually the controversy is between the healthcare providers and the surrogates. So as far as the healthcare providers are concerned, they have a logical thinking with available resources, also with their first-hand experience with these kind of patients in the past. But the surrogates, emotional bonding with the patients is too much, and lack of knowledge about the disease and its process and the complications, and also the superstitious beliefs. Once we had a patient, 28-year-old female with staph pneumonia, and she developed a lot of blisters all around the body with multi-organ failure. So we counseled the patient, the attenders, for DNA or DNR. Instead, the patient attenders counseled us, saying that you don't worry, doctor. There is a priest who is going to give some paste ground out of some leaves, and we are going to get it tomorrow and place it in the left great toe. Within 20 seconds, the patient will be all right. Be confident. That's all the response we got. And we are left with no other choice. It is a democratic country. We have to wait for it. They came and placed the paste, and they didn't improve. And finally, they came to the terms and then signed the DNR. So superstitious beliefs are too much here, unlike what we saw in London, and also unrealistic expectations. So ways to avoid these complications. Elective. So when we are going to initiate the ECMO electively, then allow at least more than one discussion with the family members to give a clear idea about what we are going to do with the patient, and what are the realistic expectations out of the patient, the costs involved, and what are the various uncertainties involved. So that they have some time to go and think about it, discuss with their family members or the family physicians, and get back to us and ask the questions and then proceed. We should have at least more than one discussion with the family members if it is an elective. For emergency, we do have with no other option like ECPR. We have to go and initiate the ECMO, and then after initiation of the ECMO, after stabilization, come and talk to the family members, and then about the various realistic things, what we are expecting, what we are not expecting, and what are the uncertainties involved, so that we all travel together. And documentation is very, very important. In all cases, especially in cases where there is a possibility of medical legal things. Consent, written consent is very mandatory, and if the facility is available, the video consenting is also good. Video consenting, when I discuss with the lawyer, says that it is not going to protect you 100% from legal issues, but at least it will helps you when you discuss with the relative at the end of the life care to come into terms, saying that these are all explained before and recorded. So transparency is very important. With uncertain recovery, mortality and morbidity are all should be discussed, which is very must here. Also, daily interaction with the patient relatives. It should be a unified one. Like a same person discussing with the family members is good, or else a same team have to discuss with the family members empathetically, and also the skilled person should do that, so that all the answers are all the questions asked were answered appropriately, and then there is no room for any confusion. Usually the poor recovery is predicted with a VA ECMO of around 2 weeks, and VV ECMO, if the patient is going to be around 2 to 3 months, the recovery is not good. But COVID has said that these are all false, and patients have recovered more than 3 months. As my colleague said, Dr. Paul Ramesh said, there are patients who has recovered after 6 months also. Let us compare India, how India is different from other countries. So in other countries, either the insurance or the National Health Services pays for them, but in India, the patient, all the surrogates have to finance the issues. Also, there is an unequal distribution of ECMO centers in India. So some people pay, some centers like cities, they have a lot of centers, where other places like villages, we don't have any centers. There is an unequal distribution. Also, which is common in both developed and developing countries, are blood and products, which there are limited to the resources. So when the patient is known that we are going to lose the patient, let us preserve as much blood as possible, blood products as possible. Also, in the COVID, most of the centers would have seen the availability of the machine. We have around 15 machines in hand, but if the referral are going to be more than that, instead of wasting our resources on a patient who is going to die in few days' time, we can prevent the patient who is young, and also chance of recovery is very high. So motivating that is very important. I'm going to restrict myself to India, ethical and legal issues. So let us answer the question, when to stop ECMO ethically. Of course, as I told you before, there is no chance for survival outside ICU, or irreversible multi-organ dysfunction with stable hemodynamics, or irreversible single organ or dysfunction without an option of transplantation or mechanical circulatory support. There are various life supports like CRRT or a ventilator, but how it is different from an ECMO. CRRT ventilator can be managed at home, so we can send them home against medical advice, and they can do whatever they want. There is an option. But ECMO, it have to be managed in an ICU setup, and shifting to home is till now it's not possible. And also when we disconnect the patient from the CRRT, the patient may go on for a few hours or days and then only die. But when you disconnect the ECMO, it is very dramatic, and the death happens very quickly. So most of the patients' relatives were really afraid to sign that off to decannulate or something like that, the ECMO. The burden what we are facing is, they also says more than 50% of the death is due to discontinuation because of organ failure or diagnosis incompetent with the life or medical futility. So the burden is too much, really. So end of life discussion, what we can do now is to request the patient relatives to sign for not to escalate or do not resuscitate. These are two options we have left. So analytic and other things, so the patient who was on ECMO, we have to discuss in two topics. One is biological life, other thing is artificial life support. In biological life, are we going to proceed the CPR or not, or else we are going to escalate the inotropes or not, to be discussed. In the artificial life support, are we going to change the oxygenator when it fails, or else we are going to increase or decrease the sweep, needs to be discussed when you are going to discuss suppose the DNA and DNR. Always shared decision making is very important. Often the emotional investment by the family members outweighs the logical thinking of the physicians, and the duration spent on the ECMO, how the patient relative feels, are that it is mostly equated to the love and affection the family shows to towards the patient. So this is very difficult to change, and always the discussion should be target or goal oriented, so that we all move together in one direction. So after discussing all these things, when the patient is not agreeing to terms, which is called as a managing impasse, so there is a disagreement between the healthcare providers and the surrogates, then suggest the second opinion from the physician of the surrogate's choice, the family attendants, the members of the family's choice. Most of the issues will be sorted out with that. But if the patient is going to have still a problem in that, then we have to go for the ethic committee. Ethic committee generally consists of a chairperson, 1 to 2 basic medical scientists, 1 to 2 clinicians from various institutes, 1 legal expert, 1 from NGO, philosopher, and a layperson from the community. So once the ethics committee has decided whatever we should abide by it, but there are exceptions. So if they suggested that to continue the care, we are going to continue. If they are going to suggest the end of life care, as I discussed before, biological end life and the artificial life supported care, both have to be discussed. And withholding transfusion is not a bad option, and not to escalate vasopressor or agree with the patient attenders to some level beyond which the digital necrosis or bowel ischemia or blisters can appear. You can explain to the patient. Most of the patient will not like their family members. Most of the relatives don't like the patients have the disfigurement, so they usually come into terms, and not to increase the support of the ECMO. As I said, the oxygenator change and all. So let us come to the legal points. How legally we can cut off the ECMO. The Article 21, which says that right to live life with dignity, which includes all aspects of life, which makes his or life meaningful, complete, and worth living. So this article, with which the Supreme Court judgment in 2016 has allowed us passive euthanasia for a patient who is brain dead on a ventilator, but the relatives approached, and they have allowed the passive euthanasia after medical board approval. But who are all to be in the medical board is an issue, and the cases are going on in that. So the bottom line is, we can't discontinue just like that. That's the bottom line, till now in India. So some case scenarios. Case 1 is 16-year-old gentleman with COVID pneumonia. We placed a VV ECMO. On day 27, he had sepsis with multi-organ failure, not able to get back to the normal routine thing. He had an irreversible multi-organ failure. So we suggested DNA and DNR, but the family were not for it, but they want some time. When we asked about the thing, they said their marriage is going to come within 4 or 5 days for some other relatives. So we waited for 4 or 5 times and 5 days, and then got the signature, and then did the routine protocol, and then left the patient. The patient died within 2 days of signing the DNA and DNR. So it's a goal-oriented approach. And case 2 is a 54-year-old female, had a cardiogenic shock. We placed a VA ECMO. CAG has showed a diffuse disease coronaries, fully awake, single organ, financial issues. So we all helped them by raising the crowdfunding, and also spoken to the management, and then did a heart transplantation for her. Case 3 is 16-year-old male with ARDS. This is a very interesting patient. VV ECMO on day 42, MDR infection on CRRT. So patient has no chance of meaningful life outside the ICU. His family wants to continue the aggressive care, so we got him to the ethics committee. Ethics committee also approves that the patient, the family have to sign DNA DNR, but the family was very adamant that they are not going to sign the DNA DNR, and even they want to prolong the treatment as much as possible in spite of a lot of counseling. So what we did is we maintained a hemoglobin of around say 7, which is legally permitted, and a protein level of something like 50 grams per day and 1,200 kilocalories, which is also legally permitted. And then we maintained low mode, so that the patient slowly weaned off, and then we couldn't save him after 17 days. These are all very difficult patient relatives to convince. And case 4 is 41-year-old male with COVID pneumonia in VV ECMO. Day 164, CT showed irreversible changes, suggested transplantation. There are some financial issues, and the ethical committee requested us to proceed with the transplantation with the help of the management, and we are awaiting a suitable organ. So let me suggest this to the future, and also ECMO Society of India, if you're able to take it to higher level and able to achieve these things, it will be very nice. A DNR should be signed along with the ECMO consent form during the initiation, so that whenever the ECMO patient is not, we are not able to wean him. So at that time, we may do a DNA or something like that. We need to explain to the family relatives, other people, and then get a signature, so that when the end of life discussion comes, it will be very easier. Acceptable law to support withdrawal of ECMO if meaningful life is not possible, or law to aid donation after cardiac death donors using ECMO. These are all the dreams what I have. Solution to ethical legal issues. So technically possible should always be decided after considering what is morally desirable. This is very, very important. Also, physician's moral decision guided by sound ethical principle as outlined in Hippocratic Oath will benefit the patient. If you follow these two, most of the ethical legal issues can be sorted. Thank you.
Thank you, Dr. Madan.